So I would say that especially now with COVID, where we kind of, become more acclimated to telehealth and maybe text message reminders, a little more savvy ways of keeping people compliant. Not everyone is with the new wave of let me get that new iPhone 12. They may still have a flip phone. Or there's some patients, as I've worked as a telehealth director for Community Health Coalition, also in Durham, people don't have phones at all. They have landlines. And so you have to find ways to communicate with the caregiver or maybe members of their community, like a church member, who can actually communicate and relay information. So it does take some creativity. It does take understanding your patient's needs and really their perspective to really start communicating, okay, here's my pharmacist action plan. Here's what I think we can do to de-prescribe or modify some regimens here and there. But it does start with having that trust and empathy for your patient.
Welcome to the Pharmacy Quality Solutions Quality Corner Show, where quality measurement leads to better patient outcomes. This show will be your go-to source for all things related to quality improvement and medication use in healthcare. We will hit on trending health topics as they relate to performance measurements and find common ground for payers and practitioners. We will discuss how the Equip platform can help you with your performance goals, and we will also make sure to keep you up to date on pharmacy quality news. Please note that the topics discussed are based on the information available at the date and time of recording. Information or guidelines are updated periodically, and we will always recommend that our listeners research and review any guidelines that are newly published. Buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. Welcome back to the PQS podcast, where we focus on medication use, quality improvement, and how we can utilize pharmacists to improve patient health outcomes. I'm your host, Nick Dorich, and on today's show, we are continuing our dive into geriatric care, or also known as senior care. We will look at barriers that geriatric care pharmacists face on a daily basis in helping their senior patients, and we'll discuss ways to overcome them. We hope after this episode that you learn a few new best practices for managing patients. For today's episode, we're going to jump right in, and we're going to meet our guest, DeLon Canterbury, PharmD, who actually happens to be local to our area based in Durham, North Carolina. DeLon, welcome to the show.
Thank you, Nick. Appreciate you having me on. It's a pleasure to be here.
Excellent. Well, before we get started with today's episode and what we're going to cover for the questions, we need to know you as the pharmacist, as the healthcare provider. So can we get a quick rundown on your background with healthcare, and can you tell us about what you do now?
Yeah, absolutely. I'd love to. So again, I'm DeLon. I graduated from the University of North Carolina in 2014 with my PharmD. I came from the community setting. So I was a retail pharmacy manager for about 6 years since I graduated. I actually ended up stepping down because really I got a bit burned out from the way that the field of retail pharmacy was. It was very metrics driven. And I feel it wasn't very outcomes focused for what was important to the patient, particularly in those that I found were either geriatric or elder in care or minorities. And there were so many gaps in the system that I felt there were other ways that we as pharmacists can integrate and help them out. And that really inspired me to start my own consulting company called Geriatrics, where today we focus on using genetic testing, medication de-prescribing, and medication management to help patients get the best out of healthcare and save some money in the process.
Excellent. Thank you, DeLon. And we'll talk more about your group, what the work is that you're doing and how that applies to de-prescribing, and appropriate use of medication is definitely a big topic for here and now. And it's incredibly important. More often than not, when you're speaking with the average person, they think about, oh, well, pharmacist, pharmacy, they just want to make sure patients are getting medications or more medications. And we often have to point out, in many cases, it's the opposite about that, right? We want to achieve the intended clinical benefit with the least amount of medications as possible. That's really what it's about, and that's what it sounds like you're working to do. So we'll touch on that, but before we do have to hear the breakdown.
Now it's time for the breakdown. As Quality Corner show host, Nick will ask 3 main topic questions. Our guests will have a chance to respond, and there will be some discussion to summarize the key points. This process will repeat for the second and third questions, which will wrap up the primary content for this recording. After that, expect to end on a closing summary, usually containing a bonus question. Now that we have described the process, let's jump into the questions.
Pharmacist Letter is offering CE credit for this podcast. Please log into your Pharmacist Letter account and look for the title of this podcast and the list of available CE courses. I'm Nick Dorich from PQS, and our guest today is DeLon Canterbury from Geriatrics. Neither of us has anything to disclose for the purposes of CE with this episode. DeLon, we know there are challenges that our patients face as they reach a senior age or when they hit that point that is clarified or identified as geriatric care. And when it comes to managing medications and healthcare coverage, it can be a bit difficult. Now, we've talked already in this series of episodes about navigating Medicare enrollment and the need for comprehensive medication reviews and how working on medications for patients that are elderly are going to be different. We know that pharmacists can help senior patients in this regard. And what I'd like to ask for you today is, what are some of those barriers that geriatric care pharmacists face, particularly when it comes to communicating with older patients? And I'll add communicating with older patients, but also caregivers or family members, since we know that comes into play. And then just a little bit of a teaser that we may dive into with this question. How has COVID and how has some of the distance approach made this more complicated?
Great question. And, it's something that we have to manage and work around on a day-to-day basis now, especially with COVID in the forefront of our communities. And so when it comes to elderly care and working with caregiving and trying to get that team-based approach and communicating a medication health action plan, you have to have an understanding of where your patient is coming from. There are a number of factors here that can affect how people communicate. Of course, there could be a psychological barrier. If you have a patient who just doesn't really relate to you, they're not going to want to talk to you. There are also, of course, physical factors. There are some patients who may have, movement disorders or an inability to speak or let alone swallow food. And so you have to find ways to communicate with them and meet them on their level. And so, especially with dealing with patients, for instance, who may be having dementia or maybe having Parkinson's, and they can't, for instance, sign their signature away for something, you have to find ways to work around that with their loved one or with a caregiver or any type of home health aide who can assist the patient. And so now when we talk about delivering medication action plans, where are you as the geriatrician coming from in terms of trust? Can you actually have a level of trust with your patient? Are you employing skills like motivational interviewing to truly assess if patients have any barriers to care? And so even when you touch on that, you have to still look at what the patient is going through. Does your patient look like you? Does your patient have any access barriers? Do they even have money? We tend to neglect that all because you have Medicare. We may think, oh, well, everything's covered, they'll be fine. But truthfully, people struggle to pay their Medicare premiums. People who are older, they simply have a fixed check or a Social Security check or retirement check that they're hopefully living off of for the entire month. So if you don't have that kind of social understanding of other barriers apart from just a med review, it's really difficult to implement changes to that plan without them truly having buy-in. And so this is where I think it's important as a pharmacist, and not just to be another person checking off lists, but to be a personal patient advocate, to be a personal, basically liaison as a part of a healthcare team to truly manage any needs, whether it's financial, whether it's transportation, whether it's health literacy. It could be a simple, smart person in front of you who's 80 years old, but they don't speak a lick of English. What's your workaround? So I would say that especially now with COVID, where we kind of become more acclimated to telehealth and maybe text message reminders, a little more savvy ways of keeping people compliant. Not everyone is with the new wave of let me get that new iPhone 12. They may still have a flip phone. Or there's some patients, as I've worked as a telehealth director for Community Health Coalition, also in Durham, people don't have phones at all. They have landlines. And so you have to find ways to communicate with the caregiver or maybe members of their community, like a church member, who can actually communicate and relay information. So it does take some creativity. It does take understanding your patient's needs and really their perspective to really start communicating, okay, here's my pharmacist action plan. Here's what I think we can do to de-prescribe or modify some regimens here and there. But it does start with having that trust and empathy for your patient.
DeLon, one question I'll ask as an immediate follow-up, and it's related to what we've discussed with some of our prior guests for this series. When we talk geriatric care and senior care, a lot of it is based on that definition being age 65 plus, and there's different clinical indications. When a patient turns 65, there may be more indications on medications that may be appropriate or inappropriate, et cetera. How does a pharmacist, or how should pharmacists think about that approach for a patient when they hit 65? Because as we heard from one of our prior guests, patients can be offended or be upset when suddenly, hey, a medication they've been taking for years is suddenly not appropriate when they hit 65, right? So from your perspective working in this space, and from your perspective as a community pharmacist or someone who has worked in community pharmacy, how do pharmacists really work to best approach that?
Yeah, sure. I like to put things with my patients basically with a two-pronged focus. And this is really just used often in medicine anyway, but I look at risks and benefits, not necessarily age. I look at the data objectively and see what's best for you as a patient. So, hey, commonly we hear people who turn 80 or so may not need a statin anymore. There is some new evidence now stating the opposite, but in general, before we didn't have the evidence, right? So you could say, hey, because you're old enough, quote unquote, not to offend, you could technically get off this statin. But when there is pushback to that, here's how I look at it. Are we talking about your day-to-day quality of life? Like at this point, what's your quality of life? Are you okay with taking that extra medicine, in addition to your 12 others, if you are on much more, in your daily regimen? Are you compliant? Do you think there are any barriers that may affect, I don't know, cost, for instance? Because people on a fixed income are going to find ways to save money. So as a pharmacist, we are really well poised to look at things outside of just an age parameter, but look at, okay, your overall life and the overall life benefit that you'll get from this intervention. Is this truly needed? And say you're healthy as an ox. You could be better shape than me. It wouldn't really matter about your age, but more so what's your quality of life looking at. So I try to put things in terms of, okay, here are the risks, here are the benefits. And as a patient, I want you to choose. I don't want you to just have my clinical judgment be the end all be all. You have to have buy-in for the plan. So if we talk about ways that we can save you money with the potential copay gone or alleviated with getting off of that med, or if we're talking about simply just making life easy because your pill burden's down, that's one less pill for you to take, or one less reminder, or less time taking meds where you could be, enjoying life with your grandkids. Putting things in relatable, easy to digest benefits and, of course, risks for the patients are ways to get people to see things and let them choose what they think is best for them. So that's how I'd like to approach that.
Yeah, thanks for the additional considerations. And I'll move us to our next topic, and we're going to continue down that path somewhat and talking de-prescribing, but specifically zeroing in on opioids for this conversation. Certainly, there's no shortage of information about appropriate or inappropriate use of opioids and the opioid epidemic that we've been seeing happening for, I guess, really it's been recognized for the last decade, but that it's been occurring since before that. But one item I want to make sure that we're discussing for pharmacists in a 2020 morbidity and mortality CDC report, one item that was identified, I'll quote, among adults age 65 and older, 25% had at least one opioid prescription filled in 2018, including 23.5% of men and 26.1% of women. Compared with patients aged 20 to 24, those aged 65 and older were approximately 2.6 times as likely to have an opioid prescription in 2018. So really, as we think about it, opioid prescriptions increasingly used, or are being increasingly used for that older population. There can be appropriate use. We know there's differences in pain tolerance and different ailments as we age. That's included there. So specifically, you already talked a bit about de-prescribing and medication use for the elderly and the aging population, but let's focus on opioid management. Sure. What do we do? What do we need to consider with that patient population? And specifically, if we need to talk de-prescribing opioids with those patients and their providers, what are the key aspects to consider?
Absolutely. So this is something that's really needing much more clinical research in terms of actual algorithms and ways to get people off. We're kind of just throwing things to the wind and seeing how the patient does after we try a change or intervention. But I think the first thing to start with is understanding that pain is multifactorial. And when you got different people with different etiologies and different sources of pain, their pain tolerance or even willingness to get on a lower dose can be quite varied. So as a clinician, you have to assess what the patient wants to do. There are a lot of studies coming out, particularly from Australia and Canada. They have what's called the D-Prescribing Network, and they do tons of good info from pilot studies looking at, honestly, the willingness of people in this population to get off of their medications or opioids, particularly here. And so I would say that there is an interest in the caregiver and patient space and practitioner space that shows about 80% to 85% and up want to find some way to get off this med for opioids particularly. Secondly, we got to also understand and also max out other viable therapeutic interventions. So you don't always have to have opioids as the mainstay of pain management. There are several types of other drugs that can be used, whether it could be massage therapy, acupuncture, tricyclic antidepressants for those with certain types of diabetic neuropathies. There are just non-opioid regimens that can be utilized instead, or actually have been shown to be almost equivalent to the use of opioids for pain management. So I secondly want to say that there are other options that could be used in conjunction with your opioid, which can eventually lower the need for the opioid if those meds are working better themselves. And then, of course, thirdly, you got to talk about what has been tried. Like, has the patient even had an educational conversation about getting off of opioids? What are their thoughts about it? They see opioids in the news all day. And so some people have an intrinsic fear. And it's just, hey, I don't even want to touch it. So what can we do otherwise? And those people are usually fun to work with, sure. And there are those who literally had a car accident 20 years ago, and they've been on chronic opioids ever since, and nothing touches their pain. So what do you do with those patients? You have to understand going into this is going to have to be very much a varied and honestly wide-ranging space of what you can use as a clinician or geriatrician to get people potentially de-prescribed or de-escalated off of these meds. And so you have to have a bit of wiggle room for the patient to say, hey, doc, I'm in pain. And if they're in pain, there may be times while you're de-prescribing that you may have to go back up and then see how you do for another week or two or whatever, and then try to reassess again. So this isn't really a hard science. I know we like to have straight up guidelines as pharmacists, but especially with what I do with geriatrics, you have to have that concierge flexibility approach here. Now, generally, when it comes to actually tapering, they mention that about trying to reduce your daily dose by 10% to maybe up to 50% if you're more severe cases, weekly or whatever time frame you want to use, can be used gradually as an appropriate way to start the de-prescribing or gradual reduction of your morphine equivalents for opioids. But again, not a hard science. So it's not I can quote you an RCT or randomized controlled trial that says, boom, this is what's going to work. But I will say, using some resources that are out there, the Australian De-Prescribing Network, along with Canada's, has really good evidence on what they do and what they recommend for people 65 and up who have been on long-term cancer treatments. And there are wide ranges of what can be approached here. Have we talked about over-the-counter treatments? Have we talked about massage therapy? Do you have patient willingness? Because guess what? Like how I mentioned earlier, if your patient isn't even willing and you're just going to say, let's just get off this dose, you're going to have some pushback. You're going to have some potential barriers. Also, what are we doing in terms of exercise? Exercise has huge benefit. Water aerobics, cardiovascular weight-bearing exercises have been shown to help give you that natural endorphin spike, which can potentially help offset the use or need for opioids. And so we have to get an approach, a holistic model for our patients. And that does include, of course, lifestyle, your environment, your social factors. Do you have enough money to even consider exercising, or are you still working in your 70s because you don't have any other income? And so again, it's variable by patient, but it has to be a multi-layered approach on addressing their pain needs.
So, Dylan, when we're talking about this topic, and you addressed looking at the medication review, the looking at the patient holistically, we know typically for Medicare patients that, for those 65 plus, and depending on medications that they're using, disease, et cetera, typically to be available for that, once a year comprehensive medication review. But I think what you're talking about is something where that really needs to be considered almost continuously. Do I understand that correctly?
That's exactly right. That's the model that we use. We provide that ongoing continuous service with geriatrics. Yep.
Excellent. Well, I'll move to our third question, and this one's going to be a little bit different. And I want to talk about at-home care for the senior, for the geriatric population. And there are many seniors that may be living in long-term care facilities, or there may be different transitions of care that are occurring. That's also probably changed quite a bit for a myriad of reasons due to COVID-19. So, from your perspective, what precautions are pharmacists taking now when it comes to working with these patients? And this may not be something where, community pharmacists are working with this, but there's various consultant pharmacists that are working with these patients and other care providers. How has this changed in the last, year and a half? And what kind of changes do we expect to see for that type of patient care going forward?
Yeah, spot on. So in this home health aid space, LTC space, it's a little bit of a different world. But honestly, COVID has changed a lot. And so we have to look more for compliance and regulatory factors to really mitigate the risk of spread, particularly in those settings. So there'll be some extra precautions regarding that. But when it comes to the actual, basically the way that our medication action plans are dispensed and put into action, they tend to be similar. We have seen changes, of course, in what we've had to prepare for, but really we're looking for ways to still keep people engaged. And so when people are in isolation, people's behaviors change in these settings, okay? If you don't have enough social engagement, we have higher risk factors for depression, higher risk factors for mood disorders, and less control of chronic conditions if they're not compliant. So consultant pharmacists are still doing an amazing job, especially in COVID, whether it be through telehealth or whether we're running with an iPad, whatever the case is, to make those things happen. Now, regarding the actual implementation, that is a little bit tricky, especially with now people are kind of scared. We have to get to that point of people, even I've had a patient who I recommended that she needed some respite care, but she refused because her loved one had Parkinson's and was unfortunately on his way out. But she refused to have respite care because she was in the middle of the pandemic. And of course, her Medicare would have completely covered it. He would have gotten some rehabilitative services to get him more ambulatory because he was just kind of out of it around the house. So the need for OT, which is occupational therapists, physical therapists, speech therapists, has probably vastly increased during COVID. The need for those services are there. But when it comes to medication management, sometimes you have to physically be in the room to really see what's in that pill bottle, to really see if they are compliant. It's not all about fill dates. If they're not taking it, but they're filling them, you don't know that through a telehealth call, right? You have to be there in person to make the intervention. So I will kind of reiterate, you do have to use open-ended terminology when speaking to patients in these settings. Of course, when consultant pharmacists are in rounds or doing their chart reviews, they're going to still do what they have to do to be in compliance with FDA and Medicare law. That's never going to change. But using the telehealth can probably bridge some of those gaps, but access to those telehealth services can still be a barrier, especially if we're talking about rural communities and so forth.
One of the first comments you made that really hooked me was the talk around isolation and loneliness that can be exhibited for patients and how that can lend itself to further healthcare issues. Are there any particular screenings or screening tools that are helpful for understanding that kind of mental well-being that pharmacists or consultant pharmacists can use? And then just additionally, and I'm thinking from your experience as a community pharmacist, are there other things that community pharmacists can use as ways or to identify some of those tendencies so they can help with the outreach and care coordination for patients?
Yeah, since it's on the topic of pretty much pain management, I will at least preface by saying that pain is expressed completely differently when you become an older citizen. Okay. It's not your usual owie, I have a hurt, I need to go get. It doesn't really work that way. And so you have to kind of look at some of those social cues, those kind of body language cues to really get a feel for what a patient's going through, for instance, for pain. Pain could be expressed by, believe it or not, having a lack of appetite, or just not, or waking up late, or being more tired throughout your day. There are other subtle changes in the body's behavior that can exhibit pain in people that are over 65, or those who may not even be able to communicate that pain. But also, there's several great assessments. I think a pretty easy one is the PHQ-9, Patient Health Questionnaire 9. 9 quick questions to really assess any suicidal ideation, mood changes, etc. Now, I work a lot, particularly with those with dementia, and so they like to do, mental MMSEs, or mini mental status exams. They have MOCA, another a mental cognition exam as well. But I will say sometimes just getting that caregiver input is really your best source of information if you're dealing with someone who has a caregiver. So that next of kin or loved one, whoever is their caregiver, really is your bread and butter when it comes to looking and spotting those changes in behavior. And again, it could manifest in many different ways: lack of appetite, sudden changes in memory. It could be just acting out of it. And that could be a sign of pain or an underlying issue contributing to something else going on.
Great. Well, thank you for that response. And DeLon, with that, I believe we've now reached the closing segment for today's show. We could cover a lot more on geriatric care, deprescribing. We'll save that for another time. And I do want to thank you for joining today's show. It's been really great and informational. And this is the point of our show where we usually ask one more question, and it typically does not pertain to pharmacy. And this topic, I think, is going to be a little pharmacy adjacent. What I'd like to hear about from you is, and this is, I think, a really commendable action, but you've been working here in the Durham, North Carolina community, specifically as an executive board member for the African American Minority COVID Task Force Plus, and would really love to hear from you. What has that group been doing the last year and a half? What's been your role with that? And from your experience, what messages are important from your perspective to share with pharmacists that can be related to managing patients with COVID, talking immunizations, and whatever else? So I'll leave that bit of an open-ended question for you.
Okay, perfect. So yeah, I'm a part of the African American COVID Task Force. We founded last year around March, where we kept seeing a growing need in the Durham community for not only having vaccination testing in low income and marginalized communities, but also eventually providing vaccination clinics in those very same communities. Unfortunately, access to care is a big deal. And what we're seeing with COVID especially is a horrible mirror of how broken our healthcare system is. And those who don't have the means or access or really the funds tend to be the ones who are affected the most by COVID. As you may know, minorities, those Black, Latino, and Native American, were dying 2 to 3 times more than our white counterparts during COVID. And so with that need at the back of our minds, there were 9 founders who started this African American COVID task force, which is really a coalition of some medical doctors from Duke, some community-facing organizations, some local nonprofits, and other local healthcare clinics. And all we do is share resources, share knowledge, and provide an ongoing means to vaccinate those in need. In addition to having partnerships and educational town halls, workshops, panels, church collaborations. I mean, we literally are boots to the ground. We're knocking down doors, trying to get people vaccinated. And if not, educating them objectively with facts and resources. So I became an exec board member later in my role around last fall. And I used that platform to dispel some of those myths that you and I get on Facebook and WhatsApp or whatever group me you're in all the time. And to put things bluntly, when I started hearing the very same myths from my own sister and parents and loved ones, it put a fire under me to just be more involved in getting the word out. And so I use some of my pharmacist skills to just speak and just do forums. And what started out with just being a little town hall or meeting here on our weekly Zoom calls, Tuesdays at 12, became multiple news features. It became being on WRAL and Spectrum News and working at St. Joseph's Church and doing a full hour and a half presentation on what are in these vaccines. And so the experience of being on this exec board is not just a passion project for me, but it hits home to how so many people are so varied in how they, may take COVID itself, the vaccination process, mistrust of the government, but particularly mistrust within minority communities who have been honestly, historically abused from our medical system. And so there are reasons that people who look like me, I'm an African-American male, may have that skepticism. And I think it is completely healthy to have skepticism, but I don't want patients to get the wrong information and let that be the end all be all when it comes to clinical decisions. And so what I would say I took away the most about this was remaining grounded and empathetic to those who just don't know. And you realize there's someone like, okay, yeah, I'm anti-vax, I would never do that, blah, blah, blah. That's a very small percent, people. That's not everyone. Most people just have straight up questions that they don't have anyone trusted to really answer. And guess what? Not all people can just go do the research. They don't have the intel or necessarily the expertise to just tell what's good information and bad. They may just see it as, well, my barber said, my beautician said, my church member said, and that could be their fact. And this is what my mom does. I guess what? Your mom does it too. Like everyone's mom kind of does that. And so it kept me grounded. It kept me humble in the fact that, not everyone knows the answer. And so you have to just have that objectivity and come with the facts, but also just come with the lens of people are scared. People are just scared, man. No one wants to get COVID. And really, we have to be a little bit of a saving grace for those who just don't know any better. So I will say there are times we all get frustrated, because I definitely do, because I'm tired of the wrong info hurting people. But this has been an opportunity to not only just show that pharmacists aren't just people behind a counter, but we can be on the street, in the streets, in the communities, doing webinars, doing discussions, and changing lives and changing minds with one conversation at a time. And as a part of this, I've honestly offered free consultations for anything related to COVID with my company, Geriatrics. So we add that as an added just benefit for anyone who has questions. I pop that in my social media platforms in case people just had any concerns. I've had several people who ask me, and these are real questions, guys. Hey, I'm worried about the Tuskegee experiment. I'm worried about this in the past. Is there a vaccine that's only for Black people in the fridge, separate from other people? Is there, am I really going to lose my child if I get injected with this? And these aren't necessarily myths. It's just there are a little bit of half-truths or dissected pieces of the truth with 98% nonsense. But the problem is there's a legit fear. And if you don't understand that people have legit fear and legit history that substantiates their reason to think this way, then you're missing the bigger picture. And that's why I feel that we've had bungled the entire messaging of this, but particularly we just haven't put enough resources into the communities that most need it. And so it's not just as always black and white, no pun intended, but it really is more than what's on the surface level.
Yeah, there's two items to that. It's one, empathy. I think, DeLon, you hit the nail on the head here. People are coming from different places around what is the reason or reasons for their vaccine hesitancy. There's not a blanket approach. And even amongst, I don't know if you call them factions, but again, within certain ideas, right, there is a gradient around what is needed and what information, right? When folks say, oh, well, I need more data, or I think this is happening, there's always a follow-up question to that. And that's where the personal interactions happen. As you said, the barbershops, the church, these are all parts where as humans, we're not just a simple robot, input, output, et cetera. There's a personal experience. And that's where for folks that have been involved and have been looking to address this meeting people where they are, it really becomes such a key aspect. So I applaud you and the group's efforts for that and the continued work that they are doing. I'll be interested to see, and certainly vaccination efforts still needed, and those are still changing. But even going forward, because fingers crossed here, at some point COVID will be done with the immediacy of it, right? And it's for groups like this. How do we use these opportunities to further engage with these communities that, as you said, have been ignored or have been mistreated before? How do we continue as healthcare providers, for us as pharmacists, right? We're often pointed to as one of the most trusted healthcare professionals. How do we use these types of organizations and groups to really further promote effective patient care and being effective for these communities? So I don't know if you've got any other further comments, or if you've even thought about, hey, what are the next steps beyond COVID for all of this?
Oh, absolutely. And that's actually the beauty of why we put the plus in the African American COVID Task Force Plus. It's not just the immediate needs of COVID, it's the social barriers. And so if we aren't connecting together with different groups and nonprofits on, hey, I lost my job, can I get rental assistance? We're able to provide that. We're able to have vaccination efforts where we're combining job fairs with the vaccination clinic, or we're having them in local staples, like, for instance, the Wheels Fun Park, which is a skating rink that's historic in North Durham. I mean, when you put them in places that people are most likely going to go and most likely need them, like schools, for instance, which we had several at, I believe, Hillside and Jordan, you got to look at the bigger picture. And this is where the trigger word, the key word that I feel every pharmacist should know now are the social determinants of health. It is public health jargon all day, but it's the reality of care. Medicines manage about 80% of care, but if they can't afford them, then you're not doing anything, right? And so if we're not talking about education, if we're not talking about access, transportation, support systems, is there a social system involved? If we're not talking about those issues, then how is it going to be sustainable? And that's what ACT Plus tries to target is, are we looking at religious affiliations? Are we looking at ways to have a referral system if people really do need the help? That is what has to be in mind. And that's where the funding is also needed to make sure it stays. Otherwise, once COVID is over and done with, we're just going back to square one. And then the next crisis happens where we're suddenly shocked that more minorities are dying.
I was making a note as you were giving the final response. It always seems to happen with almost every podcast. Our guest brings up social determinants of health. And we've had series dedicated to that as a topic. I think it's going to be a dedicated series we have every year because it is a constant for folks. And really, until we address it, that's not going to change. So I did not know the inclusion of the plus part with the coalition, but now that really makes sense. So DeLon, thanks for sharing that. Now, before we do wrap up, you've provided a lot of great information, a lot of great content, and a lot of great context, whether it be for the geriatric care that we were talking about, or towards the end as we pivoted to COVID-19 and social determinants of health patient outreach. But DeLon, if somebody wants to reach out to you and has a question about any of those topics or something else altogether, what's the best way for them to reach you?
Yeah, sure. So my website is geriatrix.org. It's GeriatRx as in x-ray.org, like a pharmacist. But I'm all over social media, so you can LinkedIn me. Just search my name. I'm at Geriatrix on all of my social media handles. So Twitter, LinkedIn, Instagram, and Facebook, of course. Follow me on Geriatrix. My website has my personal email and my cell phone. So you can call me right on there or text me, whatever you need. But LinkedIn and email are great ways to connect with me. But go ahead and subscribe to my website, geriatrix.org. You actually get my top 10 pharmacy saving tips that I use for my patients for each one I help. And they're completely free. So go on and sign up.
Excellent. Well, again, thank you for appearing on today's episode, providing a lot of great information for myself, but also for our listening audience. And DeLon, we'll look forward to connecting more with you in the future. Now, for our listeners, that does wrap up our content for today's episode. So just a couple of final notes for you. Make sure you subscribe to our podcast. And if you have a question or topic, please let us know. Similarly, if you have a topic and would like to come on the show and talk about it, we would love that. You can DM us directly on Twitter at PharmacyQuality or by emailing info@pharmacyquality.com. With that, I again appreciate you listening to the Quality Corner Show, and there is one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner Show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.